Number one, first and foremost, welcome medical students to your psychiatry clerkship rotation. I want to welcome you guys. Number two, for the Wicked Nights website work group. Let's see that one quickly. I went on the website this morning. Unfortunately, one of the hyperlinks didn't work. So I think I corrected it. And I sent it back.
Yeah, let's use his audio though.
You don't have someone's, I think.
So if you could take a quick look at it, I'll get it up, and then let me know. Just text me. I'll go ahead and then alert the Twitter group to get the message out, so that the medical students and the interns can jump on that. So we have an annual Easter egg hunt, and hopefully we're within minutes of announcing that. So stay tuned. And then the third thing I just wanted to mention is that last night I posted a riddle on Instagram. So if anybody has any thoughts with regard to the solution of that riddle, please post on social media, text me, or in any other way, take your best guess. So 3 quick announcements. Without further ado, I'll leave it up to the students then. Where would you like to start in discussing our selected Seinfeld episode?
Do you mean which storyline should we start with, Dr. Tobia?
Storyline, character, any observation? Can start anywhere you'd like.
So I believe the episode begins on a scene with George at dinner with his cousin and his former fiance and his cousin, and I don't know if it's his wife or her wife, with the name Seven. And George is certainly fixated on that name. And yeah, I guess at that dinner, he goes with the name Soda first, and they don't like that name, but he really likes that name.
He does get fixated on the name Seven. And there's I think a couple of things to discuss, if not analyze here. One is, I believe your observation is that it is a fixation of George's. So hypothetically, if he came to any one of us with a chief complaint revolving around concerns of this intrusive thought of what he wants to name his baby, their baby, what are some of the things the clinician probably should investigate?
Maybe like some kind of trauma surrounding this.
Okay. Despite the fact that if you've watched all 9 seasons of Seinfeld and believe that you've uncovered trauma with regard to the character of George Costanza, I don't think you'd necessarily be wrong, but I think for this discussion's sake, let's say no evidence of prior trauma.
Any prior history of like those intrusive thoughts before, or any audio hallucinations, something along those lines, hearing voices that no one else hears?
He'll deny voices, and if you go on to examine whether or not there are any recent or past psychotic symptoms, he'll deny those as well. All right, and let's just say you've talked to Frank and Estelle, you've talked to his parents, and they confirm a history absent of psychotic features. And he does tell you that sometimes he kind of does get caught up in things where he can't push thoughts out of his mind. But otherwise, he's nondescript with regard to any precipitants or exactly how long he's been struggling with this.
What about like OCD type stuff?
All right, so give me some examples of OCD type stuff.
Yeah, so like locking the door a bunch of times, locking, unlocking, or coming back to check 5-10 times or a specific number of times, and just being particular in like places he goes, places he sits. in those locations, things like that.
Right. He'll deny that. All right. So in examining compulsive acts, he'll deny that.
We'd want to know if the thoughts cause him anxiety or stress.
That's a big one. And I would get the feeling that he would endorse that.
And then, and then like going off of what Dan and Tom were saying, perhaps like, does he do anything to undo this stress when he has these fixations on the name 7, or like, is there any sort of action to cope with that anxiety?
It's again, another great point. He'll deny that. What he'll probably tell you is that that stress gets to a boiling point very frequently for him. And it's that boiling over that he's likely to identify as causing his clinically significant distress or impairment. I'm not sure if he'll actually use those words, but we can. So all of these observations that all of the students just made certainly are building a case for obsessive compulsive disorder. I think one of the teaching points here, number one, is that the intrusive thoughts do not intensify to the point where the individual, George, does not gets to the point where he would identify them as coming from outside of his head. So with that greater intensity, more of an auditory hallucination. But because George Costanza continues to demonstrate some level of insight and recognize the thoughts being a product of his own mind, we're going to call them obsessions instead of auditory hallucinations. That's number one. Number two, and I've heard multiple students make comments about this, they must cause clinically significant distress or impairment. They do. And then finally, number three, you could make the diagnosis of OCD without any evidence of compulsions. And the inverse is also true. Even though it's not demonstrated in this particular episode, individuals who resort to compulsive acts to alleviate anxiety with no evidence of obsessions also can be diagnosed with OCD. So obsessive compulsive disorder is really defined through clinically significant obsessions and or compulsions. And that's what I think might be going on. Now, a couple of your questions probed an origin or etiology. You're asking how long, and certainly when you ask people how long they're suffering from what they're suffering from, to the extent they could give you a roundabout time of onset, the follow-up question is always whether or not something happened in or around that time. All right, so the precipitant. George's case, I'm not sure we have a clear precipitant, but nonetheless, that's where the examiner's questions would go. What do you know about George Costanza? And here I'm going to ask people to cheat, those Seinfeld fans who watched prior episodes. That is likely the etiology of his obsessive thoughts. And I think he gives a hint with regard to his behavior surrounding the name.
I know he loves the Yankees and he loves Mickey Mantle.
Mm-hmm. Definitely true. Anything more to that?
It's his dream to work for the Yankees.
Well, I think that's fair to say because he does, right? He definitely fulfills that dream. A couple of things to come up here. Number one, with regard to his love for the Yankees, this might be connecting him back to his childhood. Now, maybe not. I mean, people who have lived through the 90s, bandwagoners, certainly even in middle adulthood, can instantly become Yankee fans because they were winning, and Seinfeld, the series, the syndicated series, was popular during that time, no doubt. So that could happen. But this is something the clinician would actually inquire about. How long have you liked the Yankees, and might it actually link to an earlier developmental time. The other thing we probably know, especially with regard to Mickey Mantle, is that there may have been some contribution to this with regard to George's grandparents. I mean, dating back to the 50s. His parents as well, but certainly his grandparents would have known Mickey Mantle well. And I wonder if there's a connection there. What does that mean? Because, by the way, we don't know a single bit of information with regard to George Costanza's grandparents. And, in certainly medical history taking, the absence of that information may be a pertinent negative. There may be a reason, may in fact be a reason why we don't know any information there. So these are all questions that the psychiatrist would probe. And he does really seem fixated on a name. And again, for families, naming their child is very important. It could be generational. I'm just wondering if there's something there that is the ultimate source of George's anxiety is family centered, whether it's his parents, maybe even linking back to his grandparents in some way. And then again, for those of you who know what I'm talking about, you do know that his parents, Frank and Estelle, are a significant source of anxiety for this character. So again, I cheated a little bit, knowing them as well as I know them, right? So again, all on the table with regard to the evaluation of George Costanza's intrusive thoughts, in this case pertaining to the title of the episode, 7. Any other observations with regard to this character?
I was just wondering if there was possibly a degree of intermittent explosive disorders, like particularly with reference to the name 7 or just this name in general. Because I know in the car he had this outburst of anger when his wife was describing that the name was taken. Then also when the baby was being delivered, he yelled at the birthing mom about being selfish. Like when he had this outburst, like, what about Cache, or what about like this name? But it's all of these outbursts have been in reference to the name that was taken. So I don't know if that would actually qualify. We also don't know if there's like a degree of remorse after it. But I was just wondering what your thoughts were on that.
Very valid question. Again, I think that's a great observation. My initial thought with regard to intermittent explosive disorder, or IED, is probably not. And these are my thoughts. This would be my case formulation. Remembering that IED is or was classified in the DSM chapter, impulse control disorders not elsewhere classified. If an individual's intermittent explosiveness is attributable to another mental disorder, you wouldn't make a separate diagnosis. You would make that initial diagnosis for that particular disorder and understand that that disorder is demonstrated or manifest through intermittent explosiveness. And I think, that has to be our first observation because the American Psychiatric Association says it has to. Only after we examine and evaluate for those illnesses and we can't find any, do we look at IED as perhaps the single best diagnosis. Well, when we delve into George and we get to understand what's going on with this character, there are many diagnoses we must consider, and therefore must have higher in our differential before we get to IED. And I mentioned one generically before, and that's, I think he's struggling with an anxiety disorder. And I think this character has very poor coping strategies when it comes to anxiety. And he tends to have it bubble over. And that bubbling over is what we're seeing. So I would be careful not to diagnose IED before we really looked at different anxiety disorders. And I think obsessive compulsive disorder is high on that list for George, especially in as much as we observe his behavior in this episode. By the way, what are the other impulse control disorders? I mean, I mentioned this chapter in the DSM. What are some other disorders that are similar to IED?
Does antisocial personality disorder, would it be on there?
So antisocial is not officially in that chapter. It's in the personality disorders chapter, but to your point, it is definitely very high in the differential of disorders that in fact does present with intermittent explosiveness. So it would be in a list of disorders that we would have to delve into, work up, and rule out before we got to IED, to your point.
Like pyromania.
Perfect, right? Pyromania. Yep. Here, the focus with regard to impulsiveness is on fire setting. And one more.
Trichotillomania.
Trichotillomania was up until 2013. The American Psychiatric Association removed it from the chapter and put it in, of all things, the obsessive compulsive and related disorder chapter. So now it's considered to be part of an anxiety spectrum.
Okay.
Oppositional defiant disorder.
Oppositional defiant disorder is in fact in the newly constructed impulse control disorder chapter, as is conduct disorder, two childhood illnesses that certainly are characterized through impulsive acts. ADHD is not. The other adult illness is kleptomania. And so where the focus of impulsivity for pyromania is fire setting, for kleptomania, it's stealing. So those are the three that right now are the adult illnesses in the impulse disorder chapter. Again, that's intermittent explosive disorder, pyromania, and kleptomania. Any other characters you want to discuss this morning? Any other behaviors, plot lines you found interesting in the 7?
I mean, possibly the dresses. Like, well, so I guess I forget his name, but the brother's reaction to the dresses, and also just the dresses in general, with wearing the same dress in all of the photos on all of the dates. If that is some sort of superstitious thing that the girl likes, or if it's completely just coincidence. Also maybe an OCD sort of thing.
Yeah, it's a couple of terms you brought up here, and I think certainly piggybacking our conversation about George, the focus on the dresses extends that. So we mentioned this clinical term obsession, and now we're going to look at the superstition, otherwise referred to as the overvalued idea. All right, and what these two clinical terms have in common is that they describe deficits in thought content. All right, so this is part of a routine mental status exam where we look at and assess for thought content. Deficits in carry multiple terms, one of which is the overvalued idea. The large consensus is that the overvalued idea is defined as that deficit in thought content that is usually not deemed to be clinically significant. Now, again, the superstitions can, but I think within the field, it's regarded that when superstitions do result in clinically significant distress or impairment, we relabel them. We no longer call them overvalued ideas. Right? So in this case, I am using the terms superstition and overvalued idea interchangeably, with the clinical term or overvalued idea certainly being the one that's medicalized. And again, consensus defined by not being clinically significant. Once an individual's deficit in thought content results in clinically significant distress or impairment, it goes by a different term. Some terms include preoccupation, rumination, and obsession. For all intents and purposes, those three terms are interchangeable. The only time the clinician may use one over the other is when a specific illness that is identified is named for it. For instance, we usually don't call these intrusive thoughts that are part of obsessive compulsive disorder preoccupations. We usually call them obsessions. So just so it sounds right, we may choose one clinical term over the other when the DSM criteria also uses and specifies the clinical term in their definition. Otherwise, these are all considered to be intermediate forms: rumination, preoccupation, obsession of deficit in thought content. The most severe form is called the delusion. Excuse me, the auditory hallucination. No, I was right the first time. The delusion. The delusion is another example of deficit in thought content that separates from the intermediate deficits by the fact that, number one, it is also not based in reality, but number two, and most importantly, the individual's belief remains rigid despite being provided evidence to the contrary. And when there is a total lack of insight, we call that deficit in thought content a delusion. And so that's a quick review of some of the clinical terminology with regard to the mental status testing of thought content. All of these are referred to as themes. And the other example of thought content, the subcategories, in addition to themes, are often referred to as killer endings, KE, especially if you learn it through the acronym. That is the components of the MSc through the acronym ABC stamp liquor, right? KE in that acronym is killer endings. The other subcategory of thought content, that includes suicidality and homicidality. Deficits in thought content as well, killer endings. We probably should briefly talk about this, especially since this is the first week of your clerkship. With regard to killer endings, I think one clinical pearl is to create a neologism, right? So neologisms are words that really are not part of any identified vocabulary. But in our case, I think it'll work that if we could arbitrarily decide that SI and HI should always go together so the clinician never forgets to inquire about one when they ask about the other, right? SI-HI, one word. Suicidal ideation, homicidal ideation, one should never be inquired separate from the other. With regard to suicidal ideation, the other major teaching pearl is that the beginning of your safety assessment can not only include SI. With regard to suicidality, it must also include organized plan, imminence, and access to lethal means. A couple things about this. Number one, you must ask all of the above, especially in an OSCE, especially in practice. For purposes of your clerkship, if you forget to inquire about one of those components, you will fail your OSCE. And that's despite asking the initial question, do you have any current suicidal thoughts, and being told no. You still have to continue with the rest of the questions. To not to would be to fail the OSCE. So one of the things we usually do at bedside, once our patients tell us no SI, is to reframe the question, right? So that's good, and thank you for sharing. But there are a few additional questions I am required to review with you. I ask everyone upon first meeting them with regard to a comprehensive psychiatric evaluation. Right now, do you have any plan to harm yourself? Usually when you reframe it, patients don't look at you as if you're not listening to them. So it's very helpful, but you do have to inquire about all. When you get to access to means, the first prompt should be open-ended. Do you have any access? And irrespective of what they tell you, you should always ask the closed-ended question about access to firearms. And once you complete that questioning, SIHI, organized plan for suicide, imminence, access to means, both open and closed-ended, you've completed the initial portion of your safety assessment. And that is the only portion medical students are required to perform for the OSCE. Got about 5 minutes left. Any other characters in Seinfeld you'd like to discuss? The only other comment I want to make with regard to Jerry's girlfriend and the dresses is that I absolutely agree. I would probe any deficits in thought content. Does she have OCD as well? Or is this perhaps not clinically significant and therefore attributable to an overvalued idea? But remembering the chapter OCD currently operates in, the obsessive compulsive and related disorders, there's another related disorder that I think we need to investigate. Now, we do see the inside of her apartment. So I think the answer is going to be no, but hoarding disorder would certainly be a clinical consideration. If Larry David had consulted with our team prior to producing that episode, we may have made that apartment a tad more messy. And if so, it may have been more consistent with hoarding disorder. Now, hoarding, just to give you some brief historical perspective, hoarding was actually a DSM criterion in OCD prior to 2013. But largely due to television, it became very popular. And the task force that published the DSM-5 pulled hoarding out of OCD and created its own disorder because it was being overdiagnosed earlier in that decade, past decade. So hoarding disorder or hoarding is no longer a sign of OCD. Now hoarding disorder is actually a standalone disorder categorized in the chapter of the OCD and related disorders. That is, it is a disorder related to OCD. But again, I think because Larry David does give us a glimpse into Jerry's girlfriend's apartment, I don't think this is very high in the differential. All right, we're at the bottom of the hour. We'll close this out here. Again, reminder to everyone, really, we are about, hopefully, minutes away of launching our annual Easter egg hunt for the worksite group. Let me know if the hyperlink works, or let me know when you put the PowerPoint back up on the website. I'll check it out, make sure the hyperlinks work. Be in touch with the Twitter group to announce that it's up and going and everybody can take part in that. Otherwise, for the medical students, I'll see you about 9 o'clock for rounds. I'll see everybody back here at about 12:30 for our case discussion focused on our film of the day. Thank you.